So you want to narrow down to our objectives here. We want to remind ourselves on how to approach this victim. We also want to remind ourselves how to remove a helmet from this victim. You want to be able to immobilize this victim's C-spine. And we want to be able to do a pelvic binding in the event that our patient has a pelvic fracture, right? We need to be able to immobilize that fracture. We need to be able to learn how to turn this patient as a unit, log roll. Why is it important anyway? That this trauma victim must be rolled or turned as a unit as opposed to penduka. Yeah, we want to protect this victim's spine. Now, the final one will be to insert the spine board and to be able to remove it safely so that our patient's spinal cord remains intact. All right? So those are our brief objectives. Then, having assessed our patients in this structured manner, what else do we need to do? Very briefly, we are going to talk about it, and that is our adjuncts to primary assessment. Now, how do we approach these trauma victims? It's there. Airway first. Is my victim's airway patent? We're not going to do that practically because we have practiced how to secure our patient's airways, right? So basically the same skill, but the first thing you want to know is my victim's airway patent. When you're thinking about it, you want to protect your patient's cervical spine, all right? Trauma victims, you need to listen to the mechanism of injury so that we know, do I suspect C-spine injury, right guys? So what are some of these mechanisms of injury that might inform us there could be a C-spine?
Acceleration, deceleration.
Acceleration, deceleration. So what we are saying is that you must take a brief targeted history as you approach this victim, right guys? Because that is the only thing that is going to inform you what might have been happening or what is happening to your victim. Any other mechanism of injury that might inform you? Ejection from a vehicle, right? One more. From a height. How high?
6. There's the height of the patient.
Twice the height of the patient or more. Okay. So you suspect C-spine injury and you need to immobilize that spine. All right? Now from there, you think about your patient's breathing. You're going to assess your patient's breathing status. All right? I don't think we need to go through that because that has been done at the airway also, I suppose. Right? Yeah. So you assess the breathing status and breathe for your patient if necessary. Are we together? Now, from there, you assess your patient's circulatory status, right? How do we do it? Look at the vital signs of the patient, all right? What else?
Check for the coldness and
We look at the patient's capillary refill. Temperature, right? What else? Going up, peripheral pulses. What is their strength, right? Are they weak? Are they thready? Is it very fast? Then that informs you what is happening to this patient. Is there anything else we can do to ascertain the patient's circulatory status? That is? Cap refill tumefanya? We are assessing. Yeah? Cyanosis. What will that inform us? Breathing, maybe? Can we talk about pallor in place of cyanosis? Can we talk about our patient's heart sounds? What is your concern with the heart sounds in the background of a trauma victim? Cardiac tamponade. So what are we going to find when you listen to the heart sounds? Very good. Muffled heart sounds. When you look, you might appreciate distended neck veins. Sawa sawa. So assessment forms your basis on how you're going to manage your patient, because it is going to inform you what is possibly happening to your patient. Right, guys? Assessment, assessment, and more assessment. Very critical. We are still at C. What else can we find out?
The level of consciousness.
Patient's level of consciousness, perfusion, right? What else? Urine output, not at the ABCs, but a little later, right? I want to bring in one thing that you have already, correct. So kuna, overt bleeding, what you can see, right? What you need to do, stop it immediately, right? Concealed bleeding. How are we going to bring it out? We can do our E first. Do we have these facilities in our home setups? They are there nowadays. We only need to get it out from where it is, right, guys? If it is not there, what are we going to do? Status quo? Correct. Change agents, right? Very good. So we are going to be able to do our E first, all right? I'm not going into details because you have already done and what you should see in what settings. From there, he told us to do IV lines, big bore IV lines, right? All right. At that, IV line in, samples out. Very good. What samples in trauma do you want? Grouping and cross-matching. Very good. I just wanted to hear that one. RBS, very critical, right? We said an RBS is a vital sign. Okay, very good. So from there, we assume that we have resuscitated our patient's circulatory status. We have assessed, we have intervened, we have reassessed, and we are happy. We go to disability. What are we looking at disability? Neurological status of our patient, right? Why do you care? Where are we bothered? It will tell us a lot of what's happening to our patient, right? So I suppose all of us can do a GCS scoring on a patient. Very good. So we will not say the doctor was not there to do it, or we did not have the machine, right? So we empower ourselves for the sake of our patients, guys. Very good. From there, after doing the neurological status of your patient, still at D, what do you want to do next? Your blood sugar comes in handy here if you did not do it a little earlier. You must know your patient's blood sugar, right? Then, assess your patient's pupillary reaction, right? Why is that important? Head injury stuff? Studio? Very good. Anything else you want to do at D? Do we agree? So, I have a quick question. Are we giving anti-seizure medications on our head injury patients routinely? No. Even if they're not seizing? Because you know it's a head injury, give an anti-seizure medication?
No.
Okay, what is the current practice?
If it was witnessed.
If they're there, we give.
Yeah.
If they're not there, we are not doing prophylactically, right? Very good. All right, then we expose our patient, right? Why do we need to expose these patients? I get this patient referred from some facility. He has his belt on, he has his shirts on, he has everything on, and they're referring that patient because it was a difficult case for them to treat. What does that inform me? What do you think it tells me?
They've missed out on things that maybe they have helped the patient.
Exactly. Remember in the morning, Dr. Moy told us, we also create emergencies. Possibly if they just exposed that patient's chest, quickly listened to the breath sounds, would have realized, oh, attention pneumo, decompress and story measure. We together? So expose your patient so that you can look out for any further injuries that you could possibly patch up to save up your patient's life and improve the outcomes. Okay? I don't want to give that scenario. A patient with bee stings, nicely intubated. You know, anaphylaxis, yeah? Intubated, adrenaline infusion ongoing, all dressed up. Came in, we open him up, and what does he have all over? The stings. What were we doing? It's that serious. So expose your patients. So that is the approach. At sea, guys, if your patient is, all right, are we log rolling at primary survey or at secondary survey? Secondary survey. However, if you're not able to sort out any of these issues, your patient is still very hypotensive, you have given fluids, you're already transfusing, you have patched up the bleedings that you can see, and your patient is still very hypotensive, you can quickly log roll your patient and see, is there anything to the posterior that I'm missing? Okay, good. How do we do the fluid resuscitation? What is the fluid of choice?
I have a question.
Yes.
Whenever I have a catastrophic bleeding, where does it fall? Is it before A or it will fall at C?
Anyone who want to give him an answer?
If you are seeing overtly,
The question is catastrophic bleeding.
that's what you start with.
Do we wait to do it at C?
No.
When do we do it?
Even before A.
CA.
CA.
Sawa? CAB.
Yeah.
All right? Catastrophic. C or Z the graces? Yes. Yes.
If a patient has much bleeding internally, they treat the three areas, the chest, abdomen, the pelvis, and long bones. Do we include them at C? Since we have taken care of the chest at B, then I think for abdomen, long bones, and pelvis, do we put them at C?
It is at C that we are going to realize our patient is bleeding, possibly because he's very tachycardic, because he's hypotensive. We open up our patient and we see maybe an increasing girth of the abdomen, or you listen to the chest and you've no good air entries. You percuss, is a dull note, and you're thinking a hemothorax, you sort it out then. Is your question answered? But catastrophic bleeding that you can see at A. Okay, good. So I think that is it. Unless you have another question, we can go to the skills.
So pelvic binding comes as C.
Yes. So this structured approach mainly is in the academic, in class really. But when that patient comes, what happens? He's on the airway, she's on the IV lines, they're like done simultaneously. So if you realize now you're not able to get out your C, you now start looking why, where. Your E first comes in, you assess your pelvis, you realize it is unstable, you immobilize it. So really, these things are done simultaneously, and you have to also have some sort of a critical thinking ability so that you know what could be happening to my patient. I'm not able to sort out this. I'm not moving on until I'm able to hemodynamically stabilize my patient. Make sense? Yeah. So then suppose you do your E first and your patient has a bleed in the abdomen.
Theater.
Will you consider your D's and your E's? It is at that point you need to call in your surgeon and tukisonga. Sindio? So yeah, care has to be done. As soon as you identify a problem, you fix it.